The risk actually goes beyond simply the infection risk, because if we broaden that concept of risk and think about the resources necessary to care for patients with COVID, we also have to think about the risk to other patients from our inability perhaps to provide a ventilator if a ventilator were needed, the fact that the operating rooms may not be available for various reasons due to needing to care for COVID patients or other staffing issues. So the risk is a very broad definition of risk.
The creation of the pMeNTS worksheet and everyone completing it, not only does it mean that the surgeon themselves have to go through all the thought processes that Dr. Slidell went through, but also then their chief usually reviews it, and then there's like a group that are in the surgical leadership that also review that. And one of the nice things I think about the pMeNTS system is that also, we have a whole lot of different surgeries that all have different scores. And so depending on the environment of your operating room or your hospital at that time, you can change what your cutoff points are for saying this is a surgery that we should do now versus a surgery that we should do later. At the height of the pandemic, we weren't doing very many surgeries that weren't urgent or emergent. So those that were truly time sensitive. And those cases usually had a score that were in, like sort of the low 40s. Cases that were in the high 40s, low 50s or above, we really critically looked at, because then that was a decision of whether or not they really should be going at that point in time or not. So I think that one of the nice things is that you can change your cut points. It's going to be flexible depending on the environment that you're in. And so like, for instance, now we have expanded our operating room to allow more cases to be done. But if, let's say that there was a surge of COVID in the next couple of days, such that ICU beds are now at a premium, and you really have to think about different resources, then you potentially could cut back and say, okay, any score that is above a level now of a 45 rather than a 55, we have to critically look at and see whether or not it should still proceed. And so, along those lines with the moral distress, it kind of takes that part out of your hands, because it's all based on a numerical value that everyone has contributed to, and everyone knows that it's a transparent system that they've come up with these ideas.
We all want to make the best decision so that our patients are at the least amount of risk, and that we don't make decisions that inadvertently affect other patients. So for example, if I schedule a procedure that I think is probably going to be able to go, a patient who will be able to go home in 2 days after a brief period of time in the hospital, but I haven't managed to think through the risks sufficiently as far as, will they need an ICU bed or not? What is the risk of blood transfusion for that patient? And I haven't had to quantify that preoperatively. Then I might make a decision that could reduce the opportunity for us to provide that bed to another patient, or may place some further constraints on our blood supply. So with respect to the blood bank, we know that's an important consideration. We've seen the impact of constrained blood supply affect patients. And that's not just the pediatric patients, but our blood bank obviously is a blood bank that is relied upon for our adult patients and as a community as a whole. So these decisions are not made in isolation as a single surgeon. And I think that's one of the great strengths of this.